Hello, my name is Karen Perry, and I'm the Manager of Information Services at the East Brunswick Public Library. I also manage the library's Just for the Health of It Health Literacy Initiative to keep our residents all healthy and well-informed about health matters. Tonight, we're so honored to be joined by Dr. Sundus Abbasi, who is a breast surgeon at Astera Cancer Care, and actually Astera Breast Care here in New Brunswick and also in Monroe Township. Dr. Abbasi received her doctorate in osteopathic medicine from Nova Southeastern University in Davie, Florida. Following a residency in general surgery at St. Joseph's University Medical Center in New Jersey, Dr. Abbasi completed a breast surgical oncology fellowship at MD Anderson Cancer Center. She is a board-certified surgeon by the American Osteopathic Board of Surgeons and is also a member of the American College of Osteopathic Surgeons, American College of Surgeons, American Society of Breast Surgeons, and the Society of Surgical Oncology. Dr. Abbasi has presented and published research in both general surgery and breast surgery. We are so welcome to be joined by Dr. Abbasi and thank her immensely for her dedication to keeping our community so healthy and informed. So welcome, Dr. Abbasi.
Hi, everyone. Thanks for coming. All right. Should we wait a little bit before we start, or should we go ahead and start?
Go ahead and start now, and people will just jump in. We have 24 people.
Okay. All right. So let me go ahead and start. Okay. So, hold on one second. Oop. Okay. So that's me right there. You can see me on the video as well. But like she said, I work at Astera Breast Center. We're in New Brunswick and we're also in Monroe. And it's myself, Dr. Hopkins, which some of you guys may know, and we have a nurse practitioner and a whole team there. And, you know, the breast centers in general, you know, a lot of places have become cancer centers where they only deal with cancer, but our breast center is very unique because we actually deal with both benign and malignant breast disease. And when people think about breasts in general, they always think breast cancer. And that is what, you know, most people focus on is breast cancer, the management, the treatment. I've done a lecture before about breast cancer. But I will tell you that the majority of patients that we do end up seeing have benign breast disease. And it's, you know, benign breast disease, I just characterize that as just to separate from malignant, meaning breast cancer. But some of it actually can be pathological. But these are the complaints that we usually see patients for, whether it's our nurse practitioner or we're seeing people for abnormal imaging. And the bulk of issues that you can have with your breast usually are characterized in what I'm going to go over in this lecture. So I'm hoping that everyone here, you know, either you know someone or you personally just want to learn more about this, because one of the major things I'm going to talk about is breast pain. And most people, I would say, do suffer from breast pain. And, you know, and a lot of times it can be alarming, but a lot of times it, you know, doesn't really result with anything pathologic, which is really good. So this is just an overview of my lecture today. I'm going to go over some breast imaging modalities. I want everyone here to be very comfortable with what type of imaging their doctor may or may not order and why they would order that type of imaging. I think it's hard as a patient, you know, you're prescribed, you know, hey, you know, do your lab work. And that's pretty self-explanatory. But sometimes when you think about preventative imaging like mammograms, you don't really know why you're getting it done. You're told to get it done, but you don't necessarily know why, and why you may need an ultrasound or why you might need an MRI. So we're going to go into that in this lecture. I'm going to talk about breast pain. I'm going to talk about nipple discharge, and then I'm going to talk about benign breast masses. So these are the masses that are most likely benign in the breast, and we just follow with imaging. And then I'm going to talk about strong family history and high-risk management. And this lecture, I also included some of the NCCN guidelines, which is the guidelines that all of us breast surgeons, practitioners, everyone go through, and really advise patients based on it. One second. Okay, first, let's just go over the breast anatomy. So the breast, I always tell patients, think about an orange. You have your peel on the outside, and then you have all this pulp on the inside, and that's your breast tissue. So what you really have is your skin. Then you have subcutaneous tissue that is not breast tissue. And then you have the rest of your actual breast tissue inside of it. It's enveloped in that layer. And within this, you have ducts and then you also have lobules. That is just anatomy. And then you can have suspensory ligaments and fat in your breast too. And then if you see the picture in the middle here, these little green circular or I say elliptical masses, those are all lymph nodes. You have all this filtering mechanism of your breast, the majority of which are underneath your arm. They're called axillary lymph nodes. And when you come in for a breast exam, everyone always checks those lymph nodes because those are the primary lymphatic drainage of the breast. And we like to see, is anything feeling enlarged or any hard lymph nodes? And then the other thing is, we think of the anatomy as a breast as clock. So when you may get a mammogram done, they may see a cyst and they'll say, hey, the cyst is at 3 o'clock. 5 centimeters from the nipple. And it's hard to know, oh, what do they mean by that? It's just looking at your breast. Centrally is the nipple and the areola. And then towards your head is 12 o'clock. Towards the bottom of your feet is 6 o'clock. And depending on which breast, out lateral is your 3 o'clock and medial is your 9 o'clock. So that is just basic anatomy of the breast. Then we go towards screening. So the screening mammogram is associated with decrease in breast cancer mortality. The NCCN guidelines recommend starting at age 4 for the average risk patient. For high-risk patients, we're going to discuss this later. We talk about getting it done earlier. And this leads to an early diagnosis of breast cancers. Mammograms can actually detect a lesion 2 years before the clinical exam. The exam is limited because everyone's breast composition is a little bit different. So there's an error in that. But with the mammogram, you can actually find lesions 2 years before. And that's why we recommend everyone to start when they're ready. And then interval cancers are actually lower among annually screened women because they're consistent with their mammograms and consistent with follow-up guidelines. So we're able to actually hopefully catch cancers early. Of course, everyone knows with COVID, what happened is a lot of people weren't getting their mammograms done. And we did see an increase in advanced breast cancers during that time. So I think now everyone has trickled down and, the impact of COVID has kind of gone away and people are back to their screening schedules. But it really did impact how we were looking at breast cancers at that time. And, a lot of patients come in and they say, oh, I'm scared to get my mammogram done. Actually, less than 10% of callbacks for your screening mammogram, which is just 2 quick views of your breast, are actually related to malignancy. So the chance if a doctor calls you back and you're worried about that, the chance that they really find something is quite low, okay? So don't be scared to get your mammograms. And just as a picture of just a mammogram, and I want to highlight what exactly are we looking at, okay? I don't know if you can see my cursor, but the middle portion of both of these images is the nipple. And you're going to see on your mammogram, think of an x-ray of your breast, kind of like we get x-rays of bones in your body. So it's going to show you a varying degree of grays and whites, okay? These dots on the left-hand side of my screen, you see these round dots, those are calcifications. Same thing on the right hand, those are also calcifications. And that is really what we're looking for when we ask you to get your mammogram done every single year, is that the earliest signs of breast cancer can look like small calcifications that are grouped together and they're different sizes. And that comes up best on the mammogram. I have some patients say, what about the radiation dose related to the mammogram, getting it every single year? You actually get more radiation going off on a flight. So you have to weigh your risks and benefits, and we would never ask patients to get something done where the risks were worse than the benefits. So the amount of radiation actually quite low, okay? On the left side, those big round calcifications, those are your breasts naturally aging. I tell patients all the time, calcifications can happen for a lot of reasons. What we got to figure out is making sure it's not the earliest signs of breast cancer, but they can happen from trauma to your breast. Trauma can be surgery, car accident, can really be anything. And it can also happen because of the natural aging of your breasts as well. The other thing that mammograms identify is your breast density, which is a really hot topic right now because a lot of women have dense breast. The extremely dense breast means that your mammogram, it's really difficult to see small lesions. And usually we talk about doing ultrasounds of your breast if you have dense breast. But it helps see the density of your breast. It helps to see asymmetries, which are tissue thickness or tissue changes in your breast. And we compare those for the ones before. So a lot of our patients that come in, this is their first mammogram, and the radiologist has identified 3 different areas that they're concerned about. You know, you have to remember they have nothing else to compare your breast to. So this is their first time really looking at it. And of course, they're going to come up with a few things they may be alarmed about, but a lot of times those really do come back as nothing. Okay. And it also looks at distortions. Distortions mean that in your breast, there is some scarring going on. And that scarring is concerning because it looks like there could be a pathological process going on. And you usually need some additional imaging. But that is the mammogram. And that is why we primarily recommend it every single year, is because it's very good at identifying those type of changes in your breast, and especially those calcifications. The next type of imaging modality we use is an ultrasound. In ultrasound, it also shows you things in gray and white matter, but the ultrasound is particularly good at looking at masses and looking at what type of masses they are, meaning what is inside of that mass. So if you look on the image on the left-hand side, okay, see how it looks very irregular, meaning it doesn't look like a circle, it doesn't look like an oval. It actually looks like it has some jagged borders to it. Those are masses that we consider to be more suspicious. You can't see the borders that well. They look angular and they look irregular, and they have the shadowing pattern associated with it. The imaging in the middle, you can see, you can make out the edges. There's dark inside, meaning fluid, but there's also this grayness in the upper left of that mass. That's a solid type of portion of a cyst, okay? And that is what ultrasound's really good at. It helps us look at cysts and help characterize them. And the last image on the right is the most benign appearing image out of all these. You can see the borders quite well. Inside is dark, meaning fluid, and this looks like one of the cysts that we see in the breast. So whenever you have an abnormal mammogram and they tell you, hey, come back, really they're asking to do some additional views of your breast using the mammogram machine, and they're going to also do an ultrasound too if they see anything that's suggestive of a mass on your mammogram. The next thing is the MRI, okay? The MRI is the most sensitive test of the breast, okay? And we use it in very particular situations because it has a very high false positive rate, meaning that it's so sensitive. What it does is they put this IV in your arm and we watch your breast in multiple phases, and we're looking at areas that basically linger with blood flow, because we know cancers like to absorb blood flow because they want to grow. So the MRI is looking for changes, but a lot of those changes can also be physiologic. So we only really use MRI in our high-risk patients and patients who have a history of breast cancer that we accept that we may have a high false positive rate. But it does lead to a lot of benign breast biopsies. I will tell you right now, a lot of patients I have seen recently, no strong family history, they have dense breasts, and they're getting MRIs done, okay? I think you have to weigh your risks and benefits for that. I personally usually like to use complete breast ultrasounds, one, because it's less invasive, and it still gives a second picture of the breast and supplement to dense breast tissue. There are some people who are getting MRIs done just based on dense breast tissue, but it really does have a high false positive rate. But those are usually the three main imaging modalities that we use in the breast. And the next thing I want you guys to be pretty comfortable with is this BI-RADS category. So this is the radiologist taking a look at your actual imaging and grading how suspicious they think a mass is going to be in terms of suggestive of malignancy. Okay, if you get a screening mammogram and they see something, they're going to give you a BI-RADS 0, meaning they have insufficient data to say what exactly they're looking at. So they're going to call you back for some additional imaging. Okay. 1 means they don't see anything. Benign means, okay, they see something, but it looks pretty benign. Okay. 3 means, and this is our talk is mostly going to talk about this 3 category. Okay. That means it's probably benign. The chance is less than 2% that it could be something suspicious. Okay. The 4, 5s, and 6, I'm not going to go into. That is more when we're thinking about something needs a biopsy and cancers. But the majority of our talk today is really going to be about these BI-RADS 3 type of findings. So let's go into our first major category, the breast pain. Okay. A lot of people have breast pain. I tell this to every single patient that comes in. They're not the first or the last person who's going to develop breast pain, okay? Breast pain is harder to treat than breast cancer. For breast cancer, we have an algorithm. We can take away the cancer, which resolves the issue. But with breast pain, it's so multifactorial. I always tell people to think about it almost like an iceberg, okay? We see it at the tip and we kind of got to just chip away at it as much as we can. But there's a lot of reasons why it's there and it may not completely go away, okay? A lot of studies have looked into breast pain, and the risk of cancer is very, very low with breast pain itself. It's about 1.2 to 6.7%, okay? And studies have found that reassurance alone usually helps resolve symptoms in 86% of women with mild pain and about half the patients with severe pain. But anyone who has new breast pain should be evaluated either by their primary care doctor or gynecologist, or even one of us at the breast center with a history and clinical breast exam. Okay, because sometimes, yes, the breast pain, the risk is still there that it could be something concerning. Symptoms of breast pain there's a lot that we look at, okay? One is the time frame, okay? If someone tells me, oh, I had breast pain every time my menstrual cycle is about to start, that is cyclical breast pain, and cyclical breast pain is less likely an indication of malignancy. But if someone says, you know what, all of a sudden, in this one portion of my breast, I have had the same pain. It's not going away no matter what I do. That is when my antenna usually goes up higher. Hey, could something really be going on here? Okay, so the location matters. Other thing is the quality of the pain. The breast, when it presents pain, is usually inflammatory pain. The breast feels heavy. The breast is burning. You may get these sharp twinges of pain here and there. Okay, that is all how the breast likes to behave. Okay, and there are some medications that I listed here that actually may contribute to breast pain. So it's very important to take a look at your medications. And some people can't get off these medications, and we have to accept the risks and benefits of staying on the medications. And sometimes we can't eliminate the breast pain, but we can decrease it as much as possible. I can't say how important it is to do a physical exam on someone who has breast pain, okay? Because you can identify a palpable mass. Maybe there's some thickening of the breast tissue that's asymmetric on one side and not the other. Maybe the patient has nipple discharge, which we're going to go into nipple discharge in a little bit. And maybe there's some skin changes that could be worrisome. There's different types of categories. So cyclic, non-cyclic, and extramammary. Okay, cyclic is usually that premenopausal, fluctuating with your menstrual cycle. Like I said, it's this heavy swelling sensation. That is really the hormone influence that is causing inflammation of the breast. And for that cyclical type of breast pain, particularly, Motrin is very good. Okay, that's anti-inflammatory. I tell my patients, put on a sports bra during your cycle. It seems counterintuitive because you're putting more pressure on your breast, but the breast loves stability, and that can really help. Or use ice or warm compresses during that time. The non-cyclic pain is a constant, sharp burning, unilateral focal pain. That's the type of pain that usually could be indicative that something is going on. And then some people don't talk about this, but there's also a lot of extra memory, meaning outside your breast reasons for breast pain. There always can be a chance of radiating breast pain to the breast. So it could be musculoskeletal, costochondritis, arthritis, respiratory, cardiac. I tell patients this all the time, and I say, listen, my job is to rule out all the scary stuff. Okay. And after that, we have to really try to chip away at this as much as possible. So a lot of times when people come to a breast center, yes, they have breast pain, but really, I think your reassurance goes a long way in knowing that the scary stuff is not happening with them. So I just want to go over the NCCN guidelines for breast pain. Okay. So if you have persistent or severe breast pain, you must do that complete history and physical. Okay. And then you have to look for these things, any breast masses, asymmetric thickening, nipple discharge, skin changes. And if I don't see any of that on the exam, meaning no physical findings, I like to ask questions. What type of pain is it? When is it happening? Is it focal pain? If it's not, if it's that cyclical pain, is reassurance and treatment if needed or desired. But if it's that focal pain, meaning in one area, constant, not going away, not fluctuating with time, that is when you really have to take a look at if you're more than 30 years old, you should really get a mammogram and ultrasound. If you're less than 30, we talk about just ultrasounds because that's how we see your breast the best. Okay. Sometimes if a patient says no, if their imaging comes back negative, I do sometimes talk about MRI for focal breast pain. Okay, but that is a informed decision, a discussion I have with the patient, accepting that high false positive rate. Okay, so symptom management. Decrease caffeine. I've had some patients come in and they say, oh, I've had an increase in my breast pain recently. I say, anything stressful going on? And they'll say, yes, this, and this. Coffee and tea, increasing your caffeine consumption. That's pro-inflammatory. Okay. Wine. No one likes to hear about the chocolate, but chocolate can increase your breast pain. I'm a culprit for the chocolate. But all these have this catecholamine release that causes hypersensitivity of the breast. So if you start to notice, hey, my breast pain is really increasing, really tune in with yourself and say, am I increasing any of these in my diet? And can I really talk about reducing it? So can I cut my coffee in half? Can I switch to a decaf? Can I, cut out one of my teas? Can I decrease the amount of chocolate? And then really, the good fitting bra is so important. This no wire bras and wearing a sports bra. Okay. Ice pack or warm compresses, I tell patients whichever one works best for them. And then the other is to decrease your fat intake. Okay, so less than 15% per day. Motrin works very well for breast pain and really to stop smoking because that is also inflammatory for the breast. Okay, the good fitting bra. I want to go back to that. I always tell patients it's not going to happen overnight. I tell them to wear their bra for 4 to 6 weeks, morning and evening. That causes stability of the breast. And I will tell you, a lot of my patients do call back and say, hey, just that one change made a big difference for me. Okay? Because the breast loves stability. Some people have the evening primrose oil, which is essential fatty acid to help decrease inflammation. The important thing about breast pain is I want you guys, if you have it, to just take one step at a time. If you overload the breast with changing so many things, you don't really know what's working for you. So I always tell patients start with the change in your bra and then Motrin and then ice warm compresses here and there, but you have to take it step by step. And that's the hard thing about breast pain because it takes time. Okay. The next thing is there's topical NSAIDs like Voltaren gel. There are some papers that have looked at that and seen that they do have a benefit and have helped breast pain. There's vitamin E, which everyone knows is anti-inflammatory. There's also flaxseed, chasteberry. There's been some studies that have looked at that and found reduction in breast pain. Usually it takes about a couple months though. There's also this androgen, Danzol, that you can prescribe. that can help decrease your breast pains. Tamoxifen, which is actually a medication we use in our breast cancer patients, has been shown to decrease breast pain. But it's really a balance, finding a way to decrease the amount of breast pain so it's not impacting your daily activities. And like what I tell patients, it takes time. It is not something that over a course of a week is just going to go away, not overnight. It takes weeks to battle breast pain, and sometimes it takes adjustments here and there. But what the key point is, the cyclical type of breast pain happening in both of your breasts, that is nothing to worry about. It's really that focal pain that does not go away. And some of my patients, they get breast pain and they start palpating their breast, meaning touching their breast in a particular area where it has breast pain. The breast is not like that, okay? The more you touch the breast tissue can get bruised, and that bruising can exacerbate the pain that you're feeling. So I say feel it, not every single day, okay? But feel it. If you're starting feeling pain, keep in tune with your body. Don't keep touching it, because it can also make it seem like your breast pain is actually more than it is. But main thing is it takes time, one step at a time, and it will get better, okay? But it just takes time. The next thing I really want to talk about is nipple discharge, because I see this a lot, okay? The nipple discharge that I worry about is the spontaneous, meaning it's happening by itself. It's only coming from one breast. It can be any color, clear, bloody, usually green is physiologic. It's persistent, meaning it keeps on coming, okay? And then you start to notice changes in your nipple, okay? The important thing is to get imaging done. Sometimes you have to get an MRI done to really take a look at it. There's a review of medications. Sometimes it's an elevated prolactin level, which usually causes nipple discharge from both of them. And then we talk about surgical options too, okay? There are some surgeries that we do for nipple discharge when we think it's very alarming. And it's not major surgery, but it's to address to see what's going on. The NCCN guidelines for nipple discharge, okay, with no palpable symptoms, okay? I want to start off at the top. So if it's non-spontaneous or multi-duct and your age is less than 40, observation, okay? I can't tell you this enough. Educate to stop compression of the breast and report any spontaneous nipple discharge. I have patients come in sometimes, and I know it's scary, but they say, oh, I have nipple discharge. And I say, does it happen by itself, or are you manipulating your nipple? And they say, oh, I squeeze my nipple and I notice nipple discharge. Do not squeeze your nipples, okay? If you're squeezing your nipples because you're having breast pain or things like that, you got to address the breast pain. But when you squeeze your nipple and notice discharge, that is trauma to your nipple, okay? That is not considered spontaneous nipple discharge. When we worry about something pathological going on, it has to be the nipple discharge that is happening by itself. So I tell people, do not squeeze your nipple anymore and let me know how it goes. And more than not, I never hear from the patient again. Okay. Then if your age is more than 40, obviously it's good to have up-to-date imaging done just to make sure there's nothing going on. And again, educate to stop compression of the breast. Okay. Then we'll drop down. So persistent and reproducible on exam, spontaneous, unilateral, single duct, clear or bloody. This is now alert. Hey, something could be going on here. Okay. So if your age is less than 30, okay, we talk about ultrasound plus or minus, getting diagnostic mammogram of the breast. And then if we don't really see anything, that is when we talk about seeing a breast specialist and getting an MRI of the breast to further characterize what may be going on, okay? If the MRI of the breast really shows nothing, this is the gray area that you really should talk to a breast specialist. So far, you have the alarming symptoms, nothing seen on your imaging. Either we can follow you up every 6 months with imaging to make sure nothing else is going on, or we talk about those surgical options in terms of investigating these ducts. And, it is not a major surgery, like I said, but it can give people a lot of reassurance as to what's going on. Okay. The next thing is when you have this imaging done and it shows a 4 to 5 category, that is when you absolutely have to see a breast specialist. I would say any of these alarm symptoms on the bottom, you should go see a breast specialist, okay? You usually start off with your primary care doctor or gynecologist, but sometimes I see patients who have nipple discharge and they've had it for many years, and then we work them up and find something. So any of those alarm systems, keep them in your mind. Those are the reasons why we worry about nipple discharge. If you're seeing discharge and it's coming from both of your breasts, that's more likely either related to your medications or physiologic, especially if you're young women, or it can be hormonal type of discharge. And if you're squeezing your nipples and noticing nipple discharge, do not traumatize your nipples anymore, okay? Let's see. So the next category I want to talk about is the bulk of what patients get when they have imaging done that's abnormal, which is a BI-RADS3 category. Remember, this means a less than 2% chance, equal or less than 2% chance, likelihood of malignancy, probably benign. But I will tell you, the BI-RADS3 scares everyone, and rightfully so. You're being told that, hey, your mammogram identified something, and it's hard to really interpret that. That is why I especially like our breast center, because we see patients who have these BI-RADS3 categories. Our nurse practitioner, Ruth, is excellent at taking care of these patients, and we also see the BI-RADS2, which is that benign category where you still feel something. This is the bulk of what, breast complaints usually are, okay? The BI-RADS3 category, I wrote, should not be made by a screening mammogram, meaning your screening mammogram, the one you're getting every single year, that is just 2 quick views of your breast. A BI-RADS3 category means they had to have done additional views that either included additional mammogram views or additional ultrasound that showed that there was concerning findings, okay? The biopsy is based on really the patient and the clinical concern. I have some patients, it's not a 0% chance, okay? The likelihood is very low, but I think it's always important to be seen by a breast specialist or maybe a specialist who is a primary care doctor who focuses on breast, because usually you need 6-month imaging, and usually we couple that with a physical exam. And it is nice to have a dedicated person who's really focusing on, because sometimes these BI-RADS3 masses do change, do get upgraded after 6 months, either they're growing or changing. And that's when we talk about biopsies. And if there's no biopsy done, which BI-RADS3 masses usually do not require biopsy because the likelihood of malignancy is very low, we do follow them up to 2 years. Okay. And I know that can be hard for a lot of people. Every 6 months you're going in for imaging. But like I said, the vast majority of masses in the breast are not the cancers. And we're so good at our imaging now that we have to be able to find a way to follow these masses and not necessarily keep biopsying your breast, okay? But I always say the BI-RADS3 is a very reasonable reason to go see a breast specialist. And like I said, in our center, we take care of a lot of these patients. Okay, I wanted to also review the NCCN guidelines for this, okay? So BI-RADS3 category, okay? Observation if low suspicion, okay? There are sometimes we review the imaging and we say, hey, you know what? This looks a little bit more suspicious to us. And then we do talk about maybe getting a biopsy, or if those suspicious cysts that we're worried about, we talk about releasing the fluid from there and seeing if anything is going on. But we usually do, follow these for about 2 years, every 6 months. And we like to follow you with a physical exam, because I have seen patients whose imaging says one story, but their physical exam says a different story. And we definitely see patients like that. So the cystic masses in the breast, okay? So these are the most common type of the BI-RADS3 categories, okay? You can have simple cysts. I always tell patients, cysts, think of water balloons in your breast, okay? They're these sac filled, and they have different types of fluid inside of it. If it's a simple cyst, this is the one that a lot of patients complain about because they're very hormonally fluctuant, so they can grow and decrease. The chance that these are related to malignancy is super, super low. Okay, and they're really just filled with fluid. So they'll swell at the time of your menstrual cycle. They may start growing and bothering you. That's when we talk about drainage of these cysts, but usually we don't worry too much about these. Okay, The next is a complicated cyst. What this means is a cyst, it has that fluid inside of it, but there's just a little bit of debris inside. And, we do talk about just short-term follow-up for those unless they start to change on the inside. The complex cyst is the cyst that has more solid inside of it. So if you think about that ultrasound picture I showed, the one that was in the middle that showed some fluid and also showed that solid component inside of it, these are the cysts where our antenna is starting to go a little bit higher. Hey, could something really be going on here? Okay. And a lot of times it depends on your age too. If you're young with a complex cyst, I think that's pretty reasonable if it's small, but if you're postmenopausal and developing these new complex cysts, that's when we're more inclined to, hey, maybe do a biopsy, okay? This is the NCCN guidelines for solid masses, these complex cystic masses, and the suspected complicated cyst. So let's start at the bottom. That complicated cyst, remember the one that has a little bit of debris on side of it? It all depends, if it's confirmed complicated cyst with visible mobility, it looks pretty benign, we can just monitor, okay? I will tell you more than not, these complicated cysts, I usually follow them every 6 months for 2 years. If it's been stable, maybe and the patient, is really tired of getting every 6-month imaging, we talk about spacing out to a year, but it has to be stable for a couple of years. And they have to also be coupled with physical exams. And then we talk about aspiration too. The complex cystic masses and the solid masses, same thing. We follow them for about 24 months to assess for stability. If they're stable and a decrease in size, wonderful. We can try to get you back to your screening mammogram. But if there's an increase, that's when we really have to talk about biopsies, okay? The biggest one, fibroadenomas, okay? These are oval masses in the breast, okay? They have a very particular ultrasound look to them. These are so common. There are some women who have it in one breast. There's some women who have a 6 in one breast, who have it in both breasts, especially the young patients. Fibroadenomas, nothing to do for these. The chance of malignancy is low unless their size is large, they're increasing on imaging. That's when we talk about surgery. In the past, everyone removed masses in the breast. Now we know we've gotten so good at imaging that we're able to characterize things so well that we can say what could be followed and what needs to actually be addressed with a biopsy. So if someone says on your imaging, hey, suggestive of fibroadenoma, more than likely it's probably a fibroadenoma, but if you're ever concerned, definitely seek additional recommendations. But I will tell you, if you have a fibroadenoma and you felt it, they'll recommend a biopsy of it. And there are some patients I see who are 14, very young, and they have these masses that they want to do biopsy. I really have a risk-benefit conversation with them. And I say, listen, you're 14, chance of cancer is really low. This is a small fibroadenoma. We can do 6-month imaging with an exam, or we can talk about biopsy. So it's always a conversation, But the BI-RADS3 also are focal asymmetries. This means your tissue is changing from your previous mammogram, and it could just be your breast aging. You age on the outside and your breast ages on the inside too. So it's going to change. And a lot of times we just have to get another baseline in 6 months and see what's going on. The other big thing is lymphadenopathy, okay? Especially after the COVID vaccine, people's breasts would swell, people's lymph nodes swell, even after any vaccine. It's a local inflammatory reaction. So sometimes they'll say, hey, this lymph node's a little bit enlarged, recommend another ultrasound in 6 months, okay? Then there's some calcifications, like we saw in that mammogram picture. Some of them we like to follow every 6 months because they look pretty benign, or there's some that we, want to biopsy, but some of those are put in that BI-RADS3 category. Another big thing is patients who've had breast cancer, okay? I always tell my patients, the first mammogram you get, you're going to get called back in 6 months, okay? We have to establish a new baseline of what your breast looks like. So a lot of post-surgical changes, they want to keep monitoring it every 6 months until it's pretty stable and not changing. And like we had already discussed, the complicated and complex cyst, okay? I will say again for these BI-RADS3 masses, it is alarming to get a mammogram that says, hey, something needs to be followed. And if you ever feel like you need to see a breast specialist to talk about it further, I would absolutely do that, because one, knowledge is power. And the more you know about your breasts, the more you know about things that you have to monitor, the better you're going to feel about your imaging. And, a lot of patients, it's hard to tell them, hey, in 6 months, we have to look at this again. But I want to reassure you, a lot of times these things are just completely benign, okay? The next thing is high-risk screening. Okay, this is a very popular topic because one of the biggest risk factors for developing breast cancer is your family history. And when do we start? Do you have a genetic predisposition? There's different types of risk models we look at. I will tell you, most people use the Gale model is good. It just looks at your lifetime increased risk with estrogen exposure, but you can only use it in women more than 35 years old. So a lot of times we're looking at the risk calculator, the Tyre-Cuzick model, the IBIS model, and that's really looking at your family history, high-risk lesions, and we're looking to see, do you have that lifetime more than 20% chance increase of breast cancer? Women who have had thoracic radiation between 10 to 30 years old are actually at a significant increased chance of breast cancer. And those are the patients that we don't want to lose to breast cancer. So we want to monitor them very closely. And of course, if you have a genetic predisposition in your family. So just to go over the Gale model, I'm just going to briefly go over it. Really what it looks at is how much estrogen exposure you've had, okay? And your family history and biopsies that you've had before. But like I said, it has its limitations. Only can use in women more than 35 years old. The Tyre-Cuzick model is the one I think most people use, and this has a lot of factors that go into it. Breast density, it's a strong family history model, looks at also your estrogen exposure, age of first pregnancy, age of menstrual cycle, menopause, it goes into all that. Looks to see, is there ovarian cancer in your family? Is there breast cancer in your family? How many members? How old were they? So it's a more detailed, I would say, type of risk factor model. And I would say I use this more often than the Gale model. Okay, so the NCCN guidelines regarding this, okay? So elements of risk, and we kind of went over this: family history, increasing age. Some women develop breast cancer and they say, oh, why did this happen to me? Sometimes there's no better answer than we are living longer, have more estrogen exposure, and that's why it happened. Okay. Ethnicity, race, lifestyle factors, increased BMI meaning the extra fats that you have in your body actually peripherally when you're postmenopausal can get converted into estrogens, okay? And that can increase your estrogen in your lifetime span, okay? If you have any estrogen hormone supplementation going on, this is a hot topic. And, I will tell you, there's a lot of different studies that have looked at this, and it's really a risk-benefit ratio. Okay. But there is some, it's all about your estrogen exposure, your reproductive history, menarche, not having children, older age of first live birth. And the birth is because your breast, when you have children, it goes through this kind of equilibrium stage. It actually has been protective in the breast. So, the earlier age of you develop, having a baby actually is more protective of your breast. If you ever have a history of these high-risk lesions in your breast, I will tell you, if any of anyone listening right now, if you have the LCIS, atypia, you're usually seen as a high-risk patient. Okay, that means your breasts are just predisposed to making these atypical cells. I mean, we just want to monitor you really closely. Okay, sometimes the increase dense patients, it doesn't, when patients have dense breasts, it doesn't mean that you're going to develop breast cancer. It just means, like what we had discussed before, it's harder to identify lesions. So you really need some sort of supplemental imaging on top of your mammogram. Okay, the thoracic radiation patients as well. Okay. So when you have patients and you're screening for this clinical encounter, include the risk assessment, okay? If you're symptomatic, that's when we start going over your symptoms and everything, but you're asymptomatic, average risk, if you're age 25 to about 40. We do clinical encounters, breast awareness. I always tell people feel it on the first. Okay, the first of the month, just feel your breast. The first time you feel it, you're going to feel a bunch of lumpies and bumpies. Then the next month, compare it, the lumpies and bumpies. Is it changing? Is it staying the same? Okay. And then your average risk, you could start the mammograms at 40. Okay. The increased risk patients, these are ones at more than 20% based on the family history model, the Tyrer-Cuzick that we went over, the thoracic radiation, the high Gale model, those atypical cells, and anything suggestive, multiple family members, you have breast cancer, ovarian cancer. That's when you talk about seeing a genetic counselor. Those are the high risk patients. Okay. And that's when we talk about clinical encounter every 6 to 12 months. And this should start when they are identified as being as increased risk, but not prior to the age of 21. Okay. Consider referral to a genetic counselor and a breast specialist. Okay. Annual screening mammograms. Those usually start 10 years prior to when the youngest family member was diagnosed with breast cancer, but not prior to the age of 30. Okay. Or the age of 40, whichever one comes first. Okay. Recommend annual MRI, also 10 years before the youngest member was diagnosed with breast cancer, not prior to the age of 25. Okay. Or start at the age 40, whichever one comes first. Okay. There's also contrast enhanced mammograms. So the patients who can't tolerate MRI, there's only some centers who do that. Or you can talk about whole breast ultrasound for those who qualify but can't undergo MRI. These are my patients who are claustrophobic, who've tried an MRI before, had some MRI, contrast allergy, or they just can't do it. It's just too claustrophobic. I do talk about doing the whole breast ultrasound. The whole idea is how can we look at your breast in different ways to help identify things early. If you're a high-risk patient, it doesn't mean that we're going to stop cancer from forming. We're looking to see how can we really identify lesions early. And that's when we talk about doing mammograms and also talking about talking about the MRIs or bilateral breast ultrasounds. Okay. And this is some more NCCN guidelines, pretty similar to, how we manage all high-risk patients, but it's really going over, do you have that atypia? Do you truly have that more than 20% lifetime risk of developing breast cancer? Okay. And I have some patients, I will tell you, who have less than 20%. Okay. I do advise them, I don't really recommend high-risk screening only because, the high false positive rate of these MRIs. And a lot of times, even with the more than 20%, I have to fight insurance companies about getting additional imaging done. But we breast specialists love to fight insurance companies, so don't worry about that. But it is hard, sometimes you say, hey, I do have, one family member with breast cancer. I'm worried about myself. That's when you really should talk to your primary care doctor and the gynecologist and see, do you qualify for this high risk screening? And you may not. And, that's fine. If you don't, because maybe you have dense breasts, we can supplement with the ultrasounds. But, sometimes additional imaging doesn't necessarily mean that you're going to develop breast cancer or that you're a high risk. This is just for our high risk patients because the false positive rate can be very high. You can probably pull someone who has atypia and almost every other MRI that we get shows something. And, I accept it, and the patient accepts it because we're really following them closely, but you really have to weigh your risks and benefits when you're not considered in that 20%. Okay. Are there some people who are less than 20%, got an MRI done and identified cancer? Yeah, sometimes yes, but it's more rare than what you think. Okay. Then people talk about risk reducing surgery. Okay. I take removing someone's breast very seriously. Okay. There's a lot of options. If you are at that high risk category, we do talk about putting you as seeing a medical oncologist. Perhaps you can take a risk reducing medication that can bring you down to the regular average risk. Or sometimes we do talk about, the risks and benefits of risk reducing surgery, such as bilateral prophylactic mastectomies. I will tell you that usually patients don't really jump to that. And I'm happy that they don't. Because I think our high-risk screening goes quite far, but I know it does put a lot of stress on patients that every 6 months you have to think, oh, is something going to come up? Is something going to come up? So it is a conversation to be had. And that's really it. Okay. This slide is where to find us. It's just our phone number. But like I said, there's myself, there's Dr. Hopkins. We see patients. I don't know why my video turned off. Can you see me now? Yeah. So, but we see patients in Monroe. We see patients in New Brunswick. We have Ruth, who is our nurse practitioner. She's excellent and sees a lot of these benign, issues of the breast. And we're always there too, in case you want one of us to swing by. But I really hope this lecture taught you a little bit what to be alarmed about, what to not be alarmed about, when to come see one of us, and I hope it really helped.
Thank you so much, Dr. Abbasi. This
Yeah.
was so interesting. I see that we had one comment or question in the chat box, which is, can we get the slides? And I responded that yes, we will send out the slides. Actually, I do have them from Dorothy. So we will send them out, Dr. Abbasi, to everyone, if that's okay with you.
Yeah, I think it's very good to know the real NCCN guidelines for everything. So I think that's a good idea.
And are there any other questions from any of our viewers tonight about anything you'd like to ask the doctor about benign breast conditions? This is your chance. So, oh, we have a question here. Hold on one second.
Oh, yes, intraductal papilloma. I'm glad you asked that. So the management of papillomas has really changed over time, okay? In the past, everyone got their papillomas removed, and there was just an article, and I actually sent it a lot. It's in the Surgical Oncology Journal, and it looked at what are the high-risk findings of papillomas, okay? So of course, everyone's imaging is a little bit differently. If you have a papilloma, I still recommend you to be seen by a breast specialist, because I want to know, did they sample this area correctly? Is it a good sample? And it can, because the papillomas, all it is a growth within your duct. If it's associated with atypical cells, if the size is more than 1 centimeter, sometimes if it's only presenting as calcifications, because usually these present as masses inside ducts, or if you have any symptoms such as nipple discharge, or there's discordant imaging, sometimes this the intraductal papillomas, when they biopsy it, they only get fragments, so they don't have enough tissue to say, hey, this is definitely an intraductal papilloma. Those are all indications that you may need surgery. But a lot of times, if it's small, you're asymptomatic, they got a good sample, we follow these. And usually they do have you see a breast specialist, because the radiologist will still on your next mammogram say, oh, recommend biopsy or recommend, surgical excision, but a lot of people aren't up to date with the papilloma treatment. But now we operate much less.
All right, thank you. We have another question. Doctor, can you see the chat box? Do you see
Yeah, I can. Let's see the next
one?
one.
How does a fat cell transfer that one?
Yeah, fat cell transfer, I don't think it necessarily would it cause you to have increased or higher risk of developing. The problem with the fat transfer into the breast, and I don't know if you've come across this yourself personally, is fat, when it liquefies over time, it becomes hard. So you'll get this fat necrosis entity, and sometimes that can mimic a hard breast mass, and it can make it a little bit difficult for the physical exam. So you may end up having more abnormal imaging with the fat transfers, but I don't think it really changes the guidelines in any way, but you may be, if you get an abnormal mammogram, you may know it because of the fat transfer. Okay.
Thank you. There's another question. Is there a connection to cancer risk from multiple biopsies?
I don't think so. Unless your biopsies came back with atypia, I don't think so. And, there's some people I know that have multiple breast biopsies and don't have any cancer. It is a trauma to your breast, it is, but we wouldn't offer breast biopsies to patients if it really significantly increased your chance. A lot of patients also ask me, if you do a biopsy of a breast mass, is it going to spread around in my breast? No, it has not been shown to be that case in breast cancers. There's certain GI malignancies where that can happen. But not necessarily in breast cancers.
And one more. If I was informed to follow up in 6 months, do I make an appointment to my regular radiology place, or can I set up an appointment with you?
Yeah, it's up to you. Some patients, feel comfortable with their gynecologist managing those BI-RADS 3 lesions. But if for any reason you want to go over your imaging and you want reassurance as to what's going on or have a second look of eyes, the good thing about breast specialists, whether it's our nurse practitioner or any of the surgeons in our office, is we look at imaging ourselves too. So sometimes, it's nice to have a second pair of eyes on everything. So I would say if you don't want to just go by just the radiologist recommendations, make an appointment. Happy to see you. Oh, is there a standard amount of biopsies? A lot of that's up to, they usually take about 8 to 9 cores, usually around, somewhere around there, but it's also up to the radiologist, depending on what method of biopsy they're using. And if they get real-time feedback about, how is the biopsy going? How are they visualizing it? And they may take some additional, it's really, that's up to the radiologist. But usually they take, anyone here who's gotten a biopsy knows they take quite a few samples, and that's because we really want to get a good sample from the area. I'll answer. You want me to keep answering these questions? Like focal area on MRI. It's hard to just say based on a focal area of MRI. It would have to be what type of enhancement was associated with it. Was it the benign type of enhancement? Was it a more suspicious type of enhancement? But, if there is a focal area of MRI that shows suspicious characteristics, usually they'll mention in your MRI itself. The BI-RADS 4 means that you need to see a breast specialist for a possible biopsy. Okay. And do clips cause pain? No, the clips, I will tell you, a lot of people ask this. The clips are so teeny tiny. When we're in the operating room removing these masses, we have to actually take an x-ray to make sure it's in our tissue itself. The pain that you end up getting that's related afterwards is bruising of the breast. The breast doesn't like to be tampered with in that way with the biopsy. So some people say, oh, I still have this residual pain to the area, but a lot of it can be the bruising after a biopsy. Sometimes I've seen patients 6 months after their biopsy, a year after their biopsy, who have really had persistent pain there. I usually get repeat imaging, and if the mass is stable, I don't recommend just removal of a clip. I think the risks of that don't outweigh the benefits. Okay, I'll do this last question. A patient cannot tolerate biopsy via ultrasound. Can you sedate the patient? Usually not, maybe there's some centers who do that, but, we have to kind of talk about the risk and benefits. I will tell you, I usually offer Xanax to my patients, and a lot of times the ones that are really nervous about their biopsy, after they take the Xanax, they can tolerate it. But there are some patients that I have that cannot tolerate these needle biopsies because, it's local anesthesia. And we do talk about surgical excision, but that is a surgery. And we have to really weigh our risks and benefits for that.
I wanted to thank Doctor again for your time and for being such a tremendous advocate for women and for our women's health. And remind everyone that the slides will be sent to all of you. This entire program is being taped and will be available on the library's website as well as on YouTube. So thank you again, everybody, and we enjoyed having you, Dr. Abbasi, and thank you again for your time and dedication to our community health.
You're welcome. Thank you guys for joining. Okay, have a good night.
Everyone.